Hello, I'm Radhika Sundararajan, and I'm delighted to speak with you today about the work that my team has done in rural Uganda. So as a brief background, we all know that HIV counseling and testing is essential to controlling the HIV epidemic. We also know that uptake of HIV testing is suboptimal in much of sub-Saharan Africa. Here are some data from Uganda, and in particular, we see in rural Uganda that uptake of testing is quite low. This middle column here shows you that only about 39% of people have received an HIV test in the past 12 months. So having an HIV test every 12 months is actually the Ministry of Health recommendation for sexually active adults living in this HIV endemic area. So we can see that the rate of HIV testing among rural inhabitants in particular is very low. This poor engagement with HIV testing has been in part attributed to use of informal healthcare providers such as traditional healers. So informal health providers don't routinely offer or discuss HIV testing, and therefore preferential use of traditional healers has been linked in many studies to delayed HIV testing and delayed diagnosis. Traditional healers are located across the landscape throughout sub-Saharan Africa, usually in or nearby the villages where people live. The World Health Organization has estimated that 80% of people of sub-Saharan Africa use traditional healers either instead of or in addition to routine biomedical services. So traditional healers are really the first line of healthcare for most people living in these endemic regions. We did a cross-sectional study in our study site of rural Uganda that showed that nearly half of adults who visit traditional healers haven't tested for HIV within the past 12 months. So these data really led us to ask, how can we collaborate with traditional healers to expand HIV testing, which is really needed among the clients that they see? So just briefly, as I mentioned, this is a study that was done in southwestern Uganda in Mbarara Township. This is a district with an HIV prevalence of about 8%, which is quite higher than the national prevalence, which is at 5%. This is a rural region, less than 200,000 residents. And across Uganda and throughout sub-Saharan Africa, there are really 4 types of traditional healers. I've listed them here. I'm not going to get into their distinctions too much, but just to say we did, for the purposes of this study, I'll tell you about, we did include traditional healers from all of these subgroups. So we really wanted to test a hypothesis, which was that traditional healers could increase uptake of HIV testing by delivering tests directly to adults receiving care at their practices. We tested this hypothesis through a parallel arm, unblinded cluster randomized control trial. The primary outcome of this trial was receiving an HIV test within 90 days of enrollment in the trial. Secondary outcomes are listed here, and these include rates of new HIV diagnosis and linkage to care for those who were newly diagnosed as living with HIV. So briefly, this is an overview of the study design. We randomized traditional healers as these individual clusters. The study outcomes were assessed at the level of the individual patients who received care from the traditional healers in the trial. All study procedures that I'll describe were delivered directly by traditional healers to their clients. And we assessed outcomes through 90-day telephone follow-up with all the trial participants. We also used a purposive sampling strategy to identify 25% of participants with whom we conducted a single qualitative interview. Here are the inclusion criteria for the trial. So traditional healers were eligible as cluster locations if they were 18 years or older. They practiced within an 8-kilometer radius of Mbarara Township, and we predetermined this distance as the distance within which participants could access the district HIV clinic, which is located in Mbarara Township, within one day. We did not want distance to be a confounding factor here. So they had to practice within 8 kilometers of that central area of Mbarara Township where the district clinic is located. And we wanted to include traditional healers who delivered care to 7 or more patients per week. And this cutoff was formulated by using data from a census that we had previously conducted among healers practicing in the region. So thereby we excluded the lowest quartile of patients per week. So this is the upper three quartiles of patient volume. Individuals receiving care at participating healers were eligible if they were 18 years or older. They were sexually active, which really was very broad, just to say that they had ever had sexual intercourse. They had to self-report no HIV testing within the prior 12 months, and therefore we defined them as having unknown serostatus according to Ministry of Health recommendations. We also required that they had not previously been diagnosed with HIV infection. So summary of the study interventions is shown here. Traditional healers in the intervention were trained to deliver HIV education to their clients, as well as pre and post HIV test counseling. We trained traditional healers in the intervention arm to offer OraQuick point of care HIV tests to eligible patients. These are non-invasive oral mucosal swab tests that are highly sensitive and highly specific. They're actually approved for layperson use in most countries in sub-Saharan Africa. Here's a picture from our training session for the intervention where we're teaching the traditional healers how to deliver these OraQuick non-invasive swab tests. And then finally, in the intervention, the traditional healers were providing local clinic information for linkage to care for those participants who did test positive on the rapid kit. Compared with the standard of care arm, we did include a one-day training session for these healers as well. They were trained to deliver HIV education to their clients and then refer their patients to a local clinic for HIV testing, which is usual care. Here's a summary of the participant flow for this trial. Between August 2019 and February 2020, we randomized 17 traditional healers in Mbarara. About 500 individuals were screened in each arm, and approximately half of the individuals that were screened were eligible for the trial. So overall, 250 participants were enrolled in each arm of the trial. And as I mentioned earlier, we selected about 25% of participants to be interviewed after 90 days. So that was 17 healers and 107 trial participants. That, just to clarify, all the healers that participated were interviewed, and then a fraction, a subset of the trial participants were included. This map shows a distribution of cluster sites across the landscape around Mbarara Township within that 8-kilometer radius, as I mentioned. The C prefix denotes control arm sites, and the I prefix denotes the intervention arm sites. Here's a summary of the characteristics of our clusters shown on the left in Table 1, and our participants shown on the right in Table 2. Moving directly to the primary outcome of the trial, we found in the intervention, all 250 individual participants who were enrolled in the intervention received an HIV test delivered by the healer. That was a 100% testing rate. In the control arm, we found that 57 of the 250 individual participants received an HIV test within 90 days of study enrollment. That's a 22.8% testing rate. And you can see those results summarized here, broken down by clusters in this graph. The black lines denote the number of participants who were enrolled at each cluster location, and the red lines indicate how many of those participants received an HIV test. So overall, we found that our traditional healer delivered HIV testing program increased the likelihood of receiving an HIV test over 4-fold compared with usual care. The difference in testing rates between our two arms was over 77%. Regarding secondary outcomes, we had some new HIV diagnoses in the intervention arm. However, 0 were diagnosed in the control arm. In contrast, in the intervention, 4% of all tests delivered were reactive, reflecting new diagnoses, and that was a total number of 10. Regarding linkage to care, 70% of those who were identified as newly living with HIV in the intervention were linked to care within 90 days. And of course, 0 were linked to care in the control because 0 were diagnosed. So how do we explain this exceptionally high uptake of HIV testing delivered by traditional healers? Well, we feel that our qualitative exit interviews were really helpful in understanding what the major factors were in driving this high uptake. First, we found that the traditional healers were really accessible, primarily because they were locally embedded. And this first quote from an intervention arm participant really underscores that this type of an intervention was felt to be very useful, particularly for people who live in these rural locations, who are living in impoverished settings, and that they are being able to access this health resource through traditional healers who live close to them, who are located close to them in the village. Second, we saw that this type of an intervention really leveraged pre-existing interpersonal relationships that existed between healers and their clients. This quote in the middle from an intervention arm participant also underscores that the people who visit traditional healers go there largely because they feel that they're very trustworthy, they're very connected. And so they felt that receiving an HIV test in the context of that interpersonal relationship was highly acceptable. And finally, interestingly, we actually had a lot of intervention arm participants describe that traditional healer setting as preferred due to confidentiality. So they actually felt that a traditional healer's practice was more confidential than a hospital, primarily because that was a space that lacked stigma. For example, people felt that going to an HIV clinic was a highly stigmatized space because by going there, you were linked to negative connotations of needing an HIV test or being in HIV care. However, traditional healers provide care for all sorts of ailments. And so going there for a test was actually a stigma-free experience for them. And in looking at the control arm, we wanted to understand, what are the barriers in usual care that are causing these low rates of HIV testing based at the facility. First was lack of transportation. This is a rural community, and they found that having to pay for transportation to go to these facilities, even though, as I mentioned, we're within an 8-kilometer radius, that distance was still perceived as too far. And so that transportation was difficult to acquire and expensive. Secondly, we found that people reported that going to an HIV clinic or any medical facility for an HIV test was a time away from income generating activities that they did not feel was a priority. And so they really prioritized the income generating activities instead of HIV testing. And finally, as I mentioned on the prior slide, stigma was a big problem, and they didn't want to go to the HIV testing facility because they didn't want to be associated with HIV, as I say here, issues in the final quote here. So this figure shows sort of a summary of, on the left, the barriers to HIV testing that we observed in usual care, which then contribute to low uptake of HIV testing services. And on the right, the facilitating factors that we identified through a traditional healer-delivered program, which of course led to extremely high uptake of HIV testing services. So we also wanted to bring light to some future directions, as we found a lot of suggestions that traditional healers could support clients throughout the continuum of care. And first, that we noted that some traditional healers actually reported linking people living with HIV to ARTs outside of the trial activities. You see in the top quote, a traditional healer who noted that one of her clients had disengaged from ART and took her back to the facility to resume. Secondly, we found that there was a need and a desire for continued support through primarily psychosocial support and adherence support. And finally, we noted that traditional healers were encouraging partner testing and disclosure strategies for to improve psychosocial support for their clients. Finally, in conclusion, we found traditional healer-delivered counseling and point-of-care testing greatly increased the uptake of HIV testing in rural Uganda, and we had significantly higher rates of diagnosis and linkage to care in the traditional healer-delivered service arm compared with usual care. We feel this evidence-based approach has real promise to increase uptake of testing in sub-Saharan Africa and beyond. I thank you for your time. There are lots of people to acknowledge, many, many partners, and I'm appreciative of the invitation to come and speak with you. Thank you.